In Heron et al. In 2019, a prospective randomized controlled trial, they assessed the effectiveness of IV thiamine in reducing hyperlactatemia and septic shock. 65 adults were included in the study with lactate of 2 millimoles per liter or higher. The treatment group received IV thiamine 200 milligrams and 50 milliliters normal saline 3 times a day for 3 days, and the placebo group just received the normal saline. No significant differences related to lactate or mortality were seen, and no change in lactate reduction over time. Mitchell et al. In 2019 was a retrospective study examining the effects of vitamin C and thiamine and hydrocortisone on reducing hospital mortality. 76 adults, mostly male, were included with diagnosis of septic shock or sepsis. The treatment group received IV vitamin C 1.5 grams every 6 hours, thiamine 200 milligrams twice daily, and hydrocortisone 50 milligrams every 6 hours. The placebo group received just the hydrocortisone. Hospital mortality did not differ significantly between groups. The ICU 28-day and 60-day mortality were not different, and ICU length of stay was significantly reduced in the treatment group. Litwack et al. In 2019 was a retrospective cohort observational study that included 94 adults receiving either the control group, which was the standard of care, hydrocortisone only, or the treatment, which was IV vitamin C, again 1.5 grams every 6 hours, 200 milligrams of thiamine every 12 hours, or 200 to 300 milligrams of hydrocortisone daily. No difference in hospital mortality or vasopressor independence was seen between the groups. Merrick et al. In 2017 was a retrospective before and after clinical study comparing outcome and clinical course of septic patients treated with IV vitamin C, hydrocortisone, and thiamine. It was done over 7 months, including 94 adults. The IV treatment group received the same vitamin C, thiamine, and hydrocortisone combination as we saw in the previous studies, and the control group received no supplementation. What they found was that hospital mortality was 8.5% in the treatment group compared to 40.4% in the control group, which was significantly less. Luger et al. 2015 was a double-blinded randomized controlled pilot study. 30 adults were included, receiving either 300 milligrams of IV thiamine or just normal saline. The thiamine group was significantly higher serum thiamine levels 2 days post-op. Mean lactate changed significantly over time, but not between groups. And additionally, 10% of the patients admitted into this study were found to be thiamine deficient at admission. Holmberg et al. Was a retrospective cohort study investigating practice patterns in thiamine administration. 53 adults with alcohol use disorders and septic shock were included. They all had lactate over 4 millimoles per liter. The treatment group got IV thiamine 100 milligrams within the first 48 hours of admission. The control group got no thiamine. Mortality overall was seen at 57%, but a significantly lower mortality rate was seen in those who received thiamine compared to those that did not. Chang et al. Was a single-blind randomized control trial. 80 adults were included. IV hydrocortisone, vitamin C, and thiamine were again used as a combination therapy versus a control group with no supplementation. No difference in mortality were seen in this group. Lactate clearance was, however, higher in the treatment group after 72 hours, but not significantly. And the final study was Fuji et al. 2020. It was a randomized open-label parallel control multicenter trial. 211 adults with lactate over 2 millimoles per liter were included. They received, again, the IV combination therapy or the placebo, which was IV hydrocortisone only. Time alone and vasopressor-free days were not statistically different, but improved SOFA scores were seen and were significantly greater in the treatment group. So tying all these studies together, 6 studies in the review saw a decrease in lactate levels or increase in lactate clearance with thiamine supplementation. Byerly et al., for example, examined both vitamin C and thiamine combined and thiamine independently as an intervention and found that even with independent thiamine supplementation, it was associated with lactate clearance. Danino et al. Similarly found lower lactate levels at 24 hours and over time in the thiamine supplemented group, which was significant compared to the placebo. While no correlation was seen between thiamine and lactic acidosis in some of the studies, when a multivariable regression analysis was performed in the Danino study and the confounding variable of liver dysfunction was accounted for, there was a statistically significant negatively correlated relationship between thiamine and lactic acidosis. This leads to the question of whether other studies that found no significant relationship between the two variables would have seen them if some of the other comorbidities were accounted for, specifically those related to liver function. Mortality was another piece that we were looking at. Mortality overall within the studies was found to be significantly improved by thiamine supplementation in 7 of the articles. Some of the articles did not examine mortality as an outcome, while others found no significant differences with thiamine supplementation. Should some of the other studies have examined this as an outcome and included this, more than 7 out of 18 possibly could have shown positive results in this category. Even in some of the studies where there was no significant difference between the thiamine supplementation and lactate levels in sepsis, an improvement in mortality was still seen. This is interesting because lactate levels were found to be an independent predictor of mortality with or without thiamine supplementation. A promising result from Merrick et al. Found that hospital mortality rate to be only 8.5% in the thiamine-treated group compared to 40.4% in the control group in their study. All of these patients in the thiamine-treated group additionally survived their ICU stay. In addition to septic-only patients, thiamine supplementation was found to improve mortality rates in other critically ill groups with sepsis, such as those admitted with alcohol use disorders or diabetic ketoacidosis. This may show potential implications for the use of thiamine in other septic subgroups for mortality benefit. Thiamine deficiency was an interesting outcome that was examined in this review. Some of the studies reviewed assessed the thiamine levels at baseline for potential deficiency, which was very helpful. One study even identified as many as 71.3% of their population that they looked at being deficient in thiamine, while others found 10, 25, 29, 35% deficiency rates at study inclusion. Thiamine deficiency was not found to be affected by insulin therapy, however, was noted to have high prevalence in the DKA populations, in addition to septic patients. It was also hypothesized that thiamine deficiency could affect mortality, specifically in the ICU. Unsurprisingly, thiamine concentrations in studies examining before and after values increased in the thiamine supplementation groups, especially when they were deficient to begin with at baseline. Interestingly, only one study also revealed that there were a higher number of patients qualifying for thiamine based on current practice recommendations, but were not receiving it at the facility. This unfortunately may have contributed to selection bias, but also lends to the larger issue of not only a high prevalence of thiamine deficiency, but also the potential for high prevalences of untreated thiamine deficiency, which could worsen outcomes in sepsis based on some of the associations we've seen in this review. Additionally, thiamine supplementation has a low risk of side effects and contraindications. This low risk of supplementation compared to a high rate of thiamine deficiency and possible positive benefits of supplementation shows another reason why supplementation should be considered in these septic patients, even currently while research remains mixed. Limited side effects mentioned in studies included hypernatremia, which is high sodium levels. However, the mentioned side effects were mostly due to the solutions that thiamine was administered in, such as the normal saline or the D5, or other parts of the combination therapy, such as the steroids, not necessarily resulting from the thiamine itself. Some of the strengths of the studies reviewed included similar intervention doses and all administered thiamine intravenously versus orally. The review included 7 randomized controlled double-blind studies, which are considered the gold standard for research design. Additionally, while studies included lactate or mortality as outcomes and included those patients with sepsis specifically with high lactate levels, they further explored other critical illnesses and comorbidities such as DKA, infection, and alcohol abuse. This is important in the determination of whether lactate and mortality improvement with thiamine supplementation in sepsis is limited to certain categories of critical illness or diagnoses, or if it can be effective in a wider range of critical illness as long as sepsis and elevated lactate levels are present. Unfortunately, this review had many limitations. Observational design in some of the studies was a big one, and noted small sample sizes was another common theme and limitations. While small sample sizes are not always a limitation, in these studies they were noted in the discussions to be a limitation and possibly a reason why significance in the results was not able to be seen, since it led to a higher risk of type 1 error. Additional studies with larger sample sizes are important to continue to explore these relationships and better assess significant associations that may not have been able to see in the current research pool. Sepsis criteria is also broad, and thus different facilities and physicians can diagnose it differently with other components of its definition, leading to the possibility of different populations and different diagnosing patterns and treatments in study locations. Additional limitations for this review included sicker populations, lack of placebo groups, comorbidities not accounted for with multivariate regression analyses, and side effects of medication and interventions that could potentially have stopped treatment early. Finally, having only one reviewer for this review is another limitation. In conclusion, thiamine was not consistently shown to improve lactate levels and mortality. However, more than half of the studies showed significant or trending inverse relationships between IV thiamine supplementation and serum lactate levels and IV thiamine supplementation and mortality in critically ill patients. Thus, more randomized, double-blind, placebo-controlled, larger studies need to be fully done in order to assess this intervention and its potential benefits in sepsis. Some implications for further research. Potential research gaps of these studies included the effects of normal saline and D5, which were typically used as the vehicle for thiamine administration on sepsis and lactate. Doses in the studies ranged from 100 to 300 milligrams per day, but larger and longer supplementation of thiamine remains unknown still in current research. One study reviewed determined that 4-day course of treatment was all that was needed for optimal results. However, this was not specifically evaluated or discussed in many of the other studies. Further research could focus on trials with higher doses of thiamine supplementation, safe upper limits for thiamine supplementation, optimal time period for supplementation, difference in lactate improvement with varying degrees of thiamine levels at baseline, and more studies on the effects of thiamine supplementation alone on sepsis and lactate levels versus combination therapy with vitamin C and/or steroids. And some of the current implementations for practice are still inconsistent. Unfortunately, this review did show mixed results on thiamine's effect on lactate levels and mortality. However, minimal negative side effects were found through the studies from thiamine supplementation, and it is an inexpensive treatment option, suggesting that it could still be used in current practice pending continued studies to support its consistent use as a standard of care, as well as specific dosing and timing recommendations. Many of the studies have alluded to the goal that earlier thiamine supplementation during critical illness being possibly more effective than later in admission supplementation. This is another important area to continue to research for application in acute patient care settings. As previously discussed, the high rates of thiamine deficiency in critically ill populations seen in some of these studies, compared to the potential high benefits that could be obtained with the supplementation and the low risks of harm, further supports the use of this in clinical practice pending further research to prove or disprove its effectiveness. There is no funding, potential bias, or conflicts of interest to disclose for this systematic review. And here are my references. Thank you for your time.